Great to meet up in virtual space, Professor Bhui, or Kam, as you are known to the world.
Very good to meet you. Yeah.
Yep. So it's an absolutely great day for us. A fascinating opportunity, my dear friends, in PGI MER Chandigarh, and I believe a few would be or should be joining from the UK as well. That's what I was told. But this primarily is for our students as well as for our alumni. I can see, oh, can you not hear me? Somebody has posted them that I'm not audible. Am I audible, Swapnajit?
I can hear you.
Yes, sir. You are perfectly fine. It's audible.
Yeah, okay. Yoginder, kindly reset your reset your audio. Right. So getting back to this is a great day for us because this is just for Professor Bhui. This is one of those speaker series which we have named as the Distinguished Speaker Series, in which we invite people of eminence all over the world to enlighten our students and our alumni and our faculty and other staff in various aspects of psychiatry, not necessarily in the hardcore, like textbook psychiatry, but going a bit beyond that, going a bit brushing with cultural aspects, with social aspects, with ethical and other kind of interfaces, really. And my dear friends, we have had people from Professor Norman Sartorius, Afzal Javed, Professor Sir Robin Murray, Professor Helen Herman, and others. But today, we are especially pleased to have among us Professor Kamaldeep Bhui, as I said, usually and better known as Bhui. He is it's my pleasure to give him a brief introduction, because the full introduction will run into pages and I don't want to eat into the time of his actual talk, so I'd rather that he addresses the students rather than me addressing. And so Swapnajit will kindly show the photograph, interestingly, of you, interestingly, along with the live person. So as you can see, my friends, Professor Kamaldeep Bhui is a professor of psychiatry at the Department of Psychiatry at University of Oxford. He wears many hats, actually. It's very difficult to talk about, and I don't know how he manages his time, to be perfectly honest. I don't know. But he is into Oxford Health, NIHR, BRC academic lead. He's the director of the World Psychiatric Association Collaborating Center based in the UK. He's a co-director, and that is particularly relevant, I believe, for us today, for the Center for Understanding Personality, in short known as CUSP. And then he's an honorary professor of psychiatry at the Queen Mary, University of London. He's an honorary consultant psychiatrist at East London and Oxford Health NHS Trust. And he was the immediate former editor-in-chief of the British Journal of Psychiatry as well. There are many others, but I'd just like to focus on one or two aspects before I leave the dais or the stage to come. He has a long-standing interest in preventing health ethnic inequalities in the experience and outcome of mental illness, and in public health related, what we call public mental health or public health interventions and policy. He has been investigating various things, but including, and importantly, adverse childhood experiences in mental health trajectories of development, and co-designed, various kind of complex systems interventions. He is a person eminently suitable to talk about this because he's other than being a psychiatrist, he's also trained in epidemiology and in psychotherapy as well. So today, as you know, the talk is on personality, its functions, and its nuances for nosology and relational therapeutics. This will also, as you know, that personality issues are becoming more and more common. Earlier, it used to be seen that in India or in this part of the world, personality disorders or personality issues were used to be diagnosed much less frequently than they used to be in the West. Way back in 2004, when I went to England in Southport as a consultant and found that, oh my gosh, there are so many people with the diagnosis of borderline personality disorder I've never seen in my life. It's no longer so nowadays in our OPD, in our setup, and it's increasing for whatever reason. I'm not going into that right now. But so this is a very important topic for all of us, Kam, and we are extremely pleased to have you amongst us. Your talk will also set as a backdrop to the 2 forthcoming series of the workshops for our students, which is going to be led by your colleague and our consultant from NHS, Dr. Tennyson Lee, who perhaps, I'm not sure if he's still there today. So that will kind of, we expect that this will set the backdrop as well as sensitize all. Oh, hi. Hi, Tennyson. Good to see you. Right. Without any further ado, my dear friends, and please understand, Kam is a person, as I've known him, as a mentor, as a friend. He's a person who would actually expect questions. He would love to be, stimulated and challenged. So please leave some time, where we can have some interaction as well. Kam, yours.
Thank you ever so much. I'm just going to screen share to make sure this is all going to work before I begin. Can you see that all right?
Yep. And
you can hear me all right?
Absolutely.
Brilliant. Okay, thank you, because I can't see anybody, so I can't see if you're smiling or grimacing.
Can you not put the Swapnajit? Can you please put the gallery? Can you put the gallery show so he can at least see some of the faces? Is that possible? Because I know otherwise it's like speaking to the screen.
Is it fine now?
So I've pulled the gallery up. It's all right.
I think you can.
Yeah, brilliant.
Right.
Yeah, thank you. Well, thank you ever so much for that lovely introduction, Debashish, and thank you for inviting me. It's a great honor, great privilege to present at your Distinguished Speaker Series. I speak with a lot of love for Chandigarh and for India. My parents are from that part of the world. My wife was born in Chandigarh and will be visiting later this year with my son. So it's exciting and important and a lovely feeling to talk to you all there. I'm sorry I can't be with you, but hopefully in the future that will be remedied. Thanks also to Debashish, because he's been a very good friend for a long time on working on WPA, World Psychiatric Association, as a colleague and as a director, and also in FRAME as a global study on adolescent mental health. And Swapnajit also, who's been doing a lot of work on psychotherapy and biology, and congratulations on your paper in the Indian Journal of Psychiatry. So thank you for inviting me, and thank you for setting this meeting up. Now, what I want to talk about today is personality, understanding personality function. And as Debashish has said, I'm going to be pushing the boundaries a little bit. I just want to start with a little bit about myself and my experiences. I've worked in community and inpatient care and assertive outreach services with street homeless people. I trained separately as a psychoanalytic psychotherapist. I've also worked with cognitive analytic psychotherapy and also in medical psychotherapy settings in the NHS. My interests have been around social and cultural psychiatry in particular, and ethnic inequalities, but I have worked with forensic services and criminal justice systems. I trained originally as an epidemiologist, but over the years working in cultural psychiatry and psychotherapy, I've become more and more vested in mixed methods research, experience-based co-design, and in particular interdisciplinary research, which is relevant to my talk today. What I've seen happen with personality difficulties and personality disorders in health settings is that they're largely neglected. People with personality disorder are largely excluded from services and marginalized. There's this concept of malignant alienation, that they are negatively treated and valued, which leads to poor outcomes, and stereotypes get played out. They seem to take up therapies that don't work for them, and 50% of people who do receive a therapy still don't recover. It's often overlooked, as Debashish has outlined, in the care of people, and they might be mislabeled as having a psychosis if they've got pseudopsychotic symptoms or dissociative states, and a whole range of other possible diagnoses. They receive multiple referrals, often rejections due to complexity and exclusion, which doesn't help someone with a personality disorder or difficulty, because their experience of early life has often been rejection and fragmentation, and then we confront them with this sort of experience. The expertise is lacking in professionals on how to manage people with personality, how to think about people with personality disorders, to manage conflicts and frustrations. And clinicians often find such patients unrewarding, even though the evidence is that they can benefit from evidenced interventions. And they have complex social and health conditions, substance misuse, violence, possibly homelessness. And this also deters people from getting involved. So with that brief introduction, what I'm going to do in my talk is outline some of the challenges we have around the care of people with personality difficulties and disorders. And that's to do with the diagnoses themselves and the contested concepts of diagnosis that we are constantly challenged by. I want to introduce some thinking around integrated models of mental illness and how they could be applied to personality disorder. We need to be evolving our theories and our concepts and our practice with contemporary neuroscience and cognitive science, as well as other branches of science. I want to then introduce some areas of new research and potential therapeutics and suggest what might be a fruitful way forward in developing relationally informed services, in particular, focusing on transference-focused therapy. Now, personality disorder and difficulty doesn't only manifest in the health arena. The top right-hand box there is essentially what drives our concern for nosology and for developing treatment and evidence. But of course, people experience the difficulties that people with personality disorder have in all sorts of other settings, in society, in schools, in prisons, where there's family breakdown. There are social and biological challenges that people face, literacy levels. People have all sorts of views about personality and personality function, and our soap operas and our films are full of unusual people and idiosyncrasies. But it's only in the health arena that we really begin to diagnose and make use of those diagnoses. And they have values, but they also have challenges. And of course, there are culturally sanctioned ways to resolve distress and visibility. And as Debasish has outlined, personality disorder hasn't been commonly diagnosed in ethnic minorities or racialized groups or in the global community. And there is an argument that maybe these are a function of high-income Western concepts of mental disorder and constructed for those particular populations. This is just a brief overview of the various diagnostic categories, ICD-10 and DSM-5. I'm going to speak more about ICD-11 in a moment, but just to summarize that there are these categories that people use: paranoid, schizoid, dissocial, emotionally unstable, borderline, histrionic, anxious, dependent, and anincastic. And most of the evidence base is on emotionally unstable personality disorder and dissocial personality disorder. Again, there are problems, even though we have these diagnostic criteria developed over decades by lots of empirical work. There are multiple criteria and symptoms, and diagnosis requires a lot of judgment. And in my experience, there's very few people I've given a single diagnosis to. They've often had multiple personality traits which are overlapping. And they are comorbid with other disorders as well, for example, depression or psychosis even. It's very difficult to treat someone with an emotionally unstable personality disorder as well as depression because you have two sort of treatment targets which require different styles of engagement. Misclassification is important. There are culturally shaped experiences that are not recognized. Clinical judgments are not always precise, and we know if you use structured instruments to diagnose personality disorder, they're better, and you get less unequal rates of diagnosis across ethnicities, for example, or cultural groups. There is persistent stigma despite diagnosis, and I'm going to talk a little bit more about what the language of personality disorder does to people's minds when they hear it. Resources. It's a Cinderella service in many places that psychosis and depression are managed, but personality disorder is not given the priority for services or research. And despite the growing evidence base, there's still limited evidence for how to treat enduring personality disorders. ICD-11, hot off the press, has changed our categorical approach to diagnosis, and it looks at dimensions, and in particular, it looks at severity and trait domains. Severity from mild to severe. It has this interesting sub-threshold personality difficulty code. It includes trait domains of negative affectivity, detachment, dissociability, disinhibition, and ankastia. The only area where the category has been retained is for this borderline personality disorder pattern specifier or emotionally unstable personality disorder. And that's because there is quite a bit of evidence there, and the psychotherapists and psychoanalysts argued that if you remove this, you are then starting again, as we will presumably have to develop new evidence to support the interventions of these new classifications. That is controversial. We can talk a bit about that perhaps in the discussion. This is the ICD-11 schema taken from a nice paper by Bobach, which looks at the degree and pervasiveness of disturbances in functioning of aspects of the self, in degree and pervasiveness of interpersonal dysfunction across various contexts and relationships. So the self and relationships are important, and then severity and chronicity of problems overall, and then whether or not there's distress, whether there's impairment in personal, family, social, educational, occupational, or other areas of functioning. So in some senses, it's not that different from our conventional understanding of what is personality as in ICD-10, but the classification has changed remarkably. We will have to generate the appropriate evidence to know how to work with this. There are problems. What does it feel like to be told you have a personality disorder? So many people who have mental health problems don't like the term disorder, particularly put next to the word personality. It's considered a pathology as opposed to a variation in ordinary functioning. It's a culturally shaped concept, potentially, that high-income countries have seen. We know if you look at prison populations, there are very high rates of personality disorder because criminality is part of the diagnosis. And so it serves a function in some places, but is it a useful category? It also assumes that the assessor and the assessee share sufficient culture for precise judgments of norms, and that might be why there are lower rates of diagnosis in particular cultures and societies and minority groups. We also know that psychometrics itself is grounded in scientific racism. We have to be very careful we don't introduce ways of partitioning people by social status and people with personality disorder being regarded as at the bottom of the pile. Clinicians find people with personality difficulties difficult to work with. They don't necessarily like them, and they often don't consider them to be like themselves, although many clinicians have lived experience themselves and manage that very well. And increasingly, there's a trend to disclose that and be open about that. We're maybe not rewarded when we work with people with personality difficulties in the same manner that the sick role affords as a model of illness for other sorts of conditions where someone is supposed to accept your recommendations and follow them to the T and is grateful, and then there's a period of time in which they recover and they go back to work or go back to functioning. It doesn't quite work like that in mental illness in general, and certainly not for personality difficulties. But I think this is a group of people who've been ignored by services and commissioners for a long time. They're often limited resources. We know there are some pan-diagnostic features emerging in mental health sciences generally, and particularly in neuroscience, particularly emotional dysregulation and impulsivity, which are very common in many personality disorders, but especially so in that borderline category. We know trauma leads to activation of the amygdala and limbic system to produce a flight response and affects autobiographical memory. So when you're working with someone with a personality difficulty or someone with trauma, it may be that they're unable to think clearly, to give a clear account of themselves. They're impulsive and they have emotional dysregulation, which is quite difficult for the clinician because they also feel that if they are empathic or not. Worryingly, 40% of clinicians working in mental health care are depersonalized, so they're not feeling anything, which makes it a problem for working with personality disorders if you really want to experience and understand and make use of transference and countertransference in your interactions. We know trauma also leads to people having difficulties in forming relationships, and so they lose friends, a phenomenon called social thinning, and they have a higher risk of multiple problems. There is a top-down regulation that neuroscience is increasingly demonstrating is helpful. Prefrontal interventions are effective at restoration, and psychotherapy may function at that level. I'll talk a bit more about that later. But certainly there are neuromodulatory devices also that are being produced now. Diagnosis and service responses are often bureaucratized. They simplify the problem. They call it a disorder and this is the pathway and this is what's going to happen. But that doesn't really work for a lot of people with personality disorder because they have such complex lives. And indeed, the emotional dysregulation and the enactments of terrible experiences early on in life also lead to disruption in their care processes, which clinicians and services find very difficult, and that often leads to a punitive exclusion. I also want to appeal to you to not distinguish between physical and mental health, and we've talked about this in other settings before, more generally in terms of parity of esteem between mental and physical health. But the exposome that we have, poverty, crime, pollution, poor housing, poor care from parents, parental neglect, emotional abuse. All of these things affect the mind and the body, and they are connected in the same sort of way. And this applies to personality as much as it does to anything else. And it's why people with personality disorder also have high levels of mortality and multiple morbidities. So I've been thinking a long time, not only about personality disorder, but mental illness in general. Well, why do people we see have such terrible lives? What happens for them to have multiple conditions? How do we explain that? That's probably the norm rather than the exception, but we do like to simplify and particularize in our clinics and in our services. Care often doesn't meet the needs. Care is often what we've been commissioned to provide. We know that people with personality difficulties have a lower life expectancy and poorer quality of life. And are we really meeting their needs and helping them? They are excluded and neglected by institutions and often by national and local policies and practices, and even hostile policies are generated locally as exclusion criteria for people who are seeking help. For example, if they're using substances or if they're using alcohol, or if they're homeless. I worked for a street homeless service, and having an address was part of receiving a service in one area of London. So I want to now move on a little bit to modernizing our concepts of personality disorder and practice, and I hope at the cutting edge of what we're thinking about in terms of improving future interventions. I want to integrate multiple theories and concepts and practices, both new and old, and bring an interdisciplinary perspective to our thinking and hopefully provoke you into reflection and challenge also. I want to foreground experience data as central to everything we must be doing. When we aren't solving a problem, we do need to take a step back and ask the person with the problem what their experience is and see that as valid, highly valid data, maybe not always generalizable, but deeply informative of mechanisms and what really is going on for them in that world, rather than dismiss it as subjective experience. Do we really know what patients want when they have this thing called a personality disorder, and what do they need? And the two might not always be the same. So, of course, I'm going to mention Freud in passing, that Freud's original concept of instincts was generated when at a time really when instinct theory and evolutionary theory were being evolved, and his argument that all organisms are born with a certain amount of instinct to help them survive, but there's also this thing called a death instinct. And you might think that's a little dated, and Freud did build his hypotheses from other sciences around him, and in a way that's what I'm inviting you to do now, is for us to rethink about personality in the context of existing sciences around us. Even dream theory, that he developed that not of entirely his invention, although he only acknowledges later on in his writings. Dreams were being thought about, and dream analysis was in place in 200 AD by Artemidorus, and Freud acknowledges that much later in his writings, but not early on enough, although in those days dreams were used as a form of precognition, as a predictive tool of what might happen in the real world, rather than an introspective tool to understand one's early life. And of course, he talked about the unconscious, the preconscious, and the conscious. And this was broadly the way that people have continued to use Freud's thinking and analysis. More recently, people have tried to modernize Freud's thinking by drawing on neuroscience, and affective neuroscience, and Panksepp's model of emotional drives has come to the fore. This is quite challenging if you want to be a modernist and you think Freud is dated and you don't want to think about instincts and needs. But Panksepp has tried to map neuroscientific findings onto Freud's findings, along with Mark Soames.
Kam, I think you're muted. Can you please unmute yourself, Kam? Yeah.
Can you hear me?
Yes.
Right, I'm not sure what happened there. Right. So affective neuroscience is what Panksepp's putting forward to map neuroscience onto needs. And he suggests we have these fundamental needs of seeking, of lust, of care, for panic and grief, for play, for rage and fear. And these are fundamental needs, which he equates with what Freud would have called instincts. And he's not just made these up. These are mapped in detailed analyses to neuroscientific concepts. Mark Soames has taken this a little further. I'm going to slow down here because this slide needs a bit of slow thinking, in Daniel Kahneman's terms. Mark Soames has mapped these needs onto the brain architecture and looks at higher cortical functions, tertiary process cognitions, largely neocortical, secondary process learning, largely limbic, hippocampus and amygdala, and bottom-up primary process emotions, which he considers to be subcortical. And we can have a debate about this, whether this is a subcortical process, is the unconscious in the subcortex, or is it in the linked to the amygdala and limbic system? And we can have these comments, but he's mapping neuroscience onto Freudian theory and puts forward some compelling arguments, particularly using Panksepp's notions of need and fundamental needs, which are fundamental and deeper than the surface phenomena that people present with, which may be seen as symptoms or cognitions. And Solm's argument, and this is something that Tennyson and I have been thinking a lot about, is very much that you can use CBT and DBT in mentalization, but they operate at a different level. And more transference-focused therapies operate at the unconscious level, where you can revise deep-seated attachment patterns and unconscious processes through consistent and persistent therapeutic interventions. So broadly speaking, the neuroscience supports this, although you might think it a bit reductive to locate particular functions in particular bits of the brain. We know the brain is a very complex system, and it's almost certain that touching one area affects the other area. And therefore, transference-focused psychotherapies are still relevant and important, even though we have CBT and DBT. And I just want to introduce TFP here, which I know will be part of your workshop over the weekend, that it's a structured therapy twice weekly. It relies on object relations theory, again, a modernization of Freudian thinking. And I've really valued that throughout my training, thinking about Winnicott and Margaret Marlowe, Kohut, and many other object relation theorists. But Kernberg in particular has talked about object relations to improve our understanding of borderline personality organization, that these are unreconciled and contradictory internal representations of self and other. And when they're in conflict, they lead to disturbance and they're effectively charged. And we put up defenses against recognizing those conflicts. And transference-focused therapy is aimed at beginning to understand that and revising those object relations. It's not dissimilar to another therapy that I've been particularly interested in, cognitive analytic therapy, where you actually draw diagrams of the different object relations to share them with the patient so that they can visualize and concretely understand what's going on in the internal world, which is sometimes difficult to hold in the external world. But of course, needs are generated not just in the Pankseppian Solms way in terms of instincts and genes, but also the environment, and needs develop from our early developmental experiences as well, depending on attachment patterns and care experiences, and whether we have been exposed to trauma, we develop other needs on top of that. And ultimately, this forms this thing called character or personality. And all of these factors are associated with higher levels of mental health problems or mental illness. And we know when you have a severe mental illness, you get social drift and social thinning and all sorts of other. So needs are complex in themselves. And although we're thinking about these fundamental, deeper needs, we also need to be aware of other areas of need that are generated. I'm going to say a little bit more about that just to ensure that when we think about therapeutics, we are also bearing in mind all these other structural and social factors. And this is the beginning of trying to integrate different concepts and theories about the mind and applying it also to personality. So we know adverse childhood experiences, one of my areas of interest, are common. Work in the lower middle income countries on this is growing, but still insufficient. If you have more than 4 to 6 adverse childhood experiences, you begin to shorten your life expectancy. We know these are not randomly distributed. People of particular age, genders, poverty level, and neurodivergence, living in precarity have higher levels of adverse childhood experiences if parental protections aren't there. There are structural factors. If there's more crime in the area you live in, if you're homeless, if you're living in care, if you're an orphan, you're more likely to experience these. And we know these affect brain development through heightened amygdala activation and limbic system activation, and lead to all those transdiagnostic phenomena that I've described about emotional dysregulation. And this can also lead to distorted cognition, heightened threat perception. People are sensitive to threats in the environment, and that affects their relationships, impaired self-care, a loss of friendships, and can lead to and have a high risk of developing mental and physical illnesses. I want to broaden that to Nancy Krieger's theories about the ecosocial that I've mentioned. Adverse childhood experiences and mental illness generally, including personality disorder, are not randomly distributed. There are wider social and political phenomena in our society which shape trajectories of health and well-being that as clinicians we probably don't pay as much attention to, but we should when we're thinking, one, about the etiology of the mental illness that we're dealing with, and two, about the complicating factors that will get in the way of recovery, that will interfere with therapeutic interventions, that maybe affect the ability that we have in our clinics to afford any intervention. If people are homeless, for example, that might be a higher priority than providing care. And this ecosocial model is applied throughout life, in utero, throughout infancy, childhood, and adulthood. So I'm just going to pause there and move on to a different model. Syndemic theory, I mentioned earlier on, what is it that leads to people having multiple health problems, living in particular places? And syndemic theory begins to help us understand that it essentially suggests that it is no surprise if you live in a very poor place with lots of adversity and you have a difficult set of social determinants around you, you are more likely to get one illness. And once you've got one, you're more likely to get a second. And they interact synergistically. So multi-morbidity or comorbidity of long-term conditions is the norm rather than the exception in particular places. And it begins to make sense of why, when we see people with personality disorder, they have so many problems that we find overwhelming sometimes. This is the original syndemic that was described, VIDA syndrome, violence, abuse, diabetes, depression, and immigration and isolation in the States. It looks at structural factors and sociocultural factors and relationship factors and individual factors. And so applying this to personality development is also important. And it's likely personality features in this, but has been silent in the analysis. And then we all know that psychotherapy is itself culturally determined to some extent, and we need to adapt psychotherapies for appropriate languages and cultures and societies depending on their norms, depending on faith, spirituality, complex identities, people's health beliefs, belief systems about what's expected of therapists and health providers. And in many places, there may not be sufficient therapists or health providers. There are family constraints, psychosocial context. And therapist-patient interactions can be undermined if the therapist isn't culturally competent. Wenqin Seng, a dear friend who passed in 2012 after attending the World Association of Cultural Psychiatry meeting in London, proposed these ways of adapting cultural therapies: philosophical transformations, theoretical adjustments, technical, and then very practical adjustments. I'm not going to go into these in detail, but there are literatures on this. So it's something to bear in mind in your workshops over the weekend, and for us thinking about transference-focused psychotherapy and how it might be used in other settings. And then the other big player is advances in neuroscience, cognitive neuroscience, 4E cognitive neuroscience. And this suggests that the mind isn't just in the brain, and that what happens to us in terms of illness, personality, mental illness generally, is not just in the brain. It's embodied throughout our physical, organic structures, and that actually all parts of the nervous system are responsive and in mutual interaction with the brain, the gut, for example. It's embedded that we're located in a particular social niche, going back to Nancy Krieger's ecosocial position, and that through that positioning, we learn particular things, we exist in particular environments. It's enacted in that we can influence our environment and therefore experience the environments we create. And there's not a binary between having to be exposed to an environment that we have no control of. And it's extended in that we can interfere and change things around us, and we interact with other people and have experiences that we can adjust. And of course, within that, there is also culture and thinking and meaning making, which influence the way we experience the world. And so I'm beginning with Tennyson to look at how we bind both cognitive neuroscience, ecosocial theory, syndemic theory, with this thing called cultural ecosocial theory, which takes account of history ancestry. I mentioned my ancestors in India. That's important, the place where you live, identity, beliefs, structures, and inequalities. And more recently, my good colleagues at McGill in Toronto and in the US at Columbia are beginning to evolve a theory of cultural, ecosocial, and cognitive neuroscience. And this really relies on systems theory, multiple dynamic systems which are linked through looping effects and are mutually constitutive. And so actually it means that genes haven't just evolved independent of culture and environment, but alongside. And our cultures also survive when they help us. And there are epigenetic effects which turn particular genes on and off at particular times, feeding into a better understanding of brain plasticity and the way we can function, and how psychotherapy can help us, and how social interventions can help us, how pharmacological interventions can help us. That these are all interconnected systems, and psychotherapy is one window. With that introduction and brief outline of the multiple theories, we wanted to propose a new approach, and I want to introduce a project here that's just been funded in the UK. Scott Weish is the lead, where we're rethinking personality completely. We want to go back to experience data and talk to people who've got this label of personality disorder and try and understand what their lives are really like, look at their biographies, understand the mechanisms through which they exist, not just the mechanisms we recognize as being diagnostically significant, but how they make sense of their world. We're trying to identify trans-diagnostic and trauma-informed approaches. We're involving people with lived experience in the co-design. We will have to think about ethical dilemmas. I mentioned concepts like personality disorder being stigmatizing, and many people don't want a diagnosis, but we also know diagnosis can be helpful in the law courts, for example, if you're charged with a crime. There's going to be a dynamic phenotyping process using data sets and network mapping. And we're trying to understand through interdisciplinary dialogue how to formulate a better way of providing care within or out with the use of diagnostic systems. And we will be developing some intervention. I'm going to talk about two of the key interventions that we're proposing to develop. One of them is transference-focused psychotherapy, actually, because we think it's really promising. And we will be developing a targeted process and trying to understand the mechanisms. And the other is RTMS, transcranial magnetic stimulation, for which there's some evidence, and I'm going to share a bit of evidence with you shortly. There are various methods we're using health economics as well as epidemiology around this, but the fundamental task is to better understand what personality is and improve interventions. There's a little bit of evidence. I won't dwell on this for too long. It's a paper that was produced by colleagues in Canada at Toronto, looking at comorbid depression and bipolar, borderline personality disorder, and finding that transcranial magnetic stimulation was helpful for the depression, although it didn't shift the borderline scores, particularly around impulsivity. That didn't change at all, but the core scores improved a little bit. But depression was definitely improved, and so it's something worth thinking about. Transference-focused psychotherapy, here's some evidence from RCTs that it reduces the levels of borderline personality organization. Schema-focused therapy appears in these studies to be slightly better than transference-focused therapy, but not better in other studies. It's more efficacious than experienced community psychotherapists, particularly in the domains of borderline symptomology and psychosocial functioning. There's preliminary evidence of superiority in the reduction of suicidality and need for psychiatric inpatient care also. And here's a recent systematic review suggesting psychotherapy, within which transference-focused psychotherapy was looked at as well, is better than treatment as usual. Reasonable effect sizes 0.5 to 0.65. Core borderline pathologies is reduced. But again, I emphasize half of the patients didn't respond. So we need much more research, much more understanding and evidence. And it's that half that I'm particularly interested in. Of course, there's no evidence that psychoactive medication is helpful for personality disorder, but it has been used for comorbidities like depression or for psychosis or anxiety. And maybe we're overusing it for those symptoms and surface phenomena rather than thinking about the deeper drives or needs, as Panksepp and Solves argued. We need earlier diagnosis and treatment, but we need better studies in both adolescents and adults. So I'm coming to the end of my talk, and I just want to summarize that what I'm trying to do in this presentation and in the wider work with Tennyson, our Centre for Understanding Personality, is to integrate multiple areas of new science, public health science, looking at psychosocial, ecosocial, and syndemic, cultural adaptations and neuroscience, and 4E cognitive neuroscience with psychodynamic thinking, in which there's a place for use of object relations theory, cognitive analytic work, transference-focused work, particularly pitting it to affective neuroscience, which is the bridge to cognitive neuroscience and other perspectives. And that means that we can use different therapies for different people who present with different phenomena, and transference-focused therapies have a particular place in that process. I'm not necessarily arguing for stepped care, because if you're unwell, you want to get the best care quickly. It requires better assessment and improving our ways of assessing what's appropriate for whom. And that in itself, as we all know, is challenging in psychotherapy assessment. We want to bring lived experience perspectives into the heart of everything we do, but we must have much more research, lived experience research, as well as epidemiology, as well as trials and evaluation, and consider cultural adaptations. I'll end with this final slide just to remind us that transference-focused therapy and transference-related therapies are focused on the unconscious and deeply ingrained levels of instinct and needs. But there are additional socio-political realities and contexts which create more needs, which either compound or are a manifestation of those fundamental needs. So trauma can lead to emotional dysregulation and impulsivity problems, and we can address those by top-down control, by stimulation of the prefrontal cortex, or using cognitive CBT, for example, and improving agencies. We need to enhance the skills of therapists for understanding these multiple levels. We really need to address stigma and thwart the negative reactions of malignant alienation. And this really means and explains and justifies the work that Tennyson and the Centre for Understanding Personality has been doing for quite a long time with Swapnajit and others, to develop a global network on improving our understanding and care of people with personality difficulties, particularly making use of transference-focused psychotherapy, but not being exclusive or competitive in noting the need for other forms of therapeutics. Also, not in neglecting the resource issues in different contexts and environments, which of course is very challenging in low and middle income countries. I'll stop there. Thank you ever so much. I hope that was helpful, interesting, challenging, thought-provoking. I assume a third of people in an audience never agree with me, so I'm assuming we'll have a discussion. So I look forward to that now. Thank you.
Right. Yeah. Can we just, yeah, exactly. Thank you very much indeed. I mean, I don't know how pleased, but also I would say how perhaps excited and also a bit confused. Perhaps I am to have this sweeping, absolutely fascinating sweep from ranging from neuroscience to sociopolitics and funneling them in an integrated model, which can, at the end of the day, hopefully can help the patient or the client or simply the person with problems. Yes, but this is not my day. This is a day of Professor Bhui, and also I can see there's a large number of people, and I'm sure that people would be interested in sharing their viewpoints. Some of them are here just for your information. We have a few very senior alumni of our department who I can see in the Swapnajit. Is it possible to for a moment to everybody to come on screen? Maybe we could take a screenshot. Can everyone please, if you're okay and not too socially compromised, just yeah, it's a holiday. Come here. It's a day of and it's afternoon. So yeah, so everybody's here to listen to you. So if you can have everybody on the screen for a moment, please, so we can have just a photo shot to remember this day. This is absolutely a fascinating day, I would say. I can see Professor Murthy. I can hear his name. Yes, sir, Professor Srinivasa Murthy. You know him, of course.
Of course, of course.
And your UK friend now, Dr. Raja Ghosh. Where is Dr. Anindya Ghosh? Yeah, I don't know if he just made a comment as well. just now. He was one of our very, very senior alumni. These are the direct disciples and students of Professor N.N. Vick. So yeah, I think we have, if you can, Swapnajit, if you could just capture maybe a snapshot or something like that. Yeah, thank you. So can I start with maybe a couple of comments from the senior members, and then we'd like to come to the young ones to really listen to their perspective. We'd like to devote some time for them. But before that, if we can have some brief words of comments or sharing, transcultural maybe, from Dr. Raja Ghosh, Dr. Murthy. I have Balaji here from Australia, I think from Melbourne. So yes, please carry on.
It was very fascinating, and there is so much of rich material. I'm going to think for quite some time to process it. Thank you, Kamal. It was very, very good. Thank you.
Thank you. Thank you so much. Thank you.
I think Dr.
It's Balaji here. Can you hear me?
Oh yes, Balaji from Melbourne. Yes, please. He's yet another of our diaspora, and Balaji is a very senior consultant psychiatrist. Are you in Adelaide or Melbourne? Where are you, Balaji?
I'm actually in Brisbane.
Oh, sorry.
Okay.
A few miles here and there. Yeah.
I know. Look, it's fascinating, Professor Bhui, and I'm just a bit fascinated about the changes in therapies that we are looking at. It's not challenging. Can I just float an idea? We are getting into newer and eclectic sort of therapies. Does that mean that we are not able to grasp the problem? Or does that mean we are still trying to figure out how best we can help people with borderline personality structure or disorder or types, etc. and etc.? So where are we in our thinking? Because we have seen over the period of past 50 years that we have been having therapies, we have been having change in the modalities, we have been having change in the aspects, how we provide the services. We have gone from pure biological to eclectic, and also now into what I'm interested is also about transgenerational concept of borderline personality as well. So my question is, in fact, comment is fascinating, fantastic, and mind-provoking lecture or a talk. But my comment is, are we there yet?
I don't think we are there yet. Traditionally, psychotherapies have been poorly evidenced and evaluated and have relied on small samples, for example, originally in the psychoanalytic world. And it's been fantastic seeing the development of third wave CBT, DBT, another form. And in the UK, we have a whole program now of providing CBT to as a first stage intervention for depression through primary care. But 50% of people in that systematic review didn't benefit at all from psychological therapy. So we have a challenge there. I think we also have a challenge in our understanding of pathways to generate evidence. And of course, we've generally followed routes like randomized controlled trials, which are really suited for simple interventions like pharmaceuticals. But for complex interventions with so many dynamic interacting parts, it's very difficult to provide a comprehensive evaluation. And therefore, the numbers of trials, perhaps with the sorts of therapies that are required for people with more complex problems, are often insufficient for them to be recommended to commissioning bodies or to be resourced. So we end up with a simplification. I guess one of my key points was that this is a really complex type of problem which has been oversimplified. And of course, in our institutions, in our commissioning frameworks and the budgets that we have to live within, everything gets bureaucratized and simplified. And of course, for many people, it doesn't work because their problems are much more complex than we are allowed. So people receiving CBT with a complex personality difficulty, undisclosed, undiagnosed, or other comorbidities isn't going to be helpful. It might help the depression, but if their personality difficulties prevent them from engaging in the first place, it's not going to be helpful, which is where I found cognitive analytic therapy quite helpful. So I think there are a number of issues there around what is evidence, what forms of evidence generation do we need, how do we escalate our pipeline and to provide interventions, whilst also bearing in mind the resources and cost of providing care for such a large number of people. So we should also be thinking about other forms of therapeutics, group therapeutics and peer support and psychoeducation, all sorts of additional supports that people can benefit from, and improving health literacy generally. So we're not there. We've got a lot more to do, but we need better models. And indeed, what I'm trying to encourage is less competition between models and more integration.
Thank you. Thank you very much indeed. Maybe we could come to, would anybody from your team come, Tennyson or I don't know, Farid, perhaps anybody would like to come? I know there's a whole workshop laid out for over the next couple of weekends, but just any preliminary comments at this stage, please, if any. Tennyson?
Dr. Basu, if I may say that there is a question in the chat. There are a couple of questions in the chat, if that's okay.
Yeah, I can pick those up.
Yeah, okay. So maybe we could take the, I can see one just now. Thanks, Balaji, for pointing that out. I think Swapnajit, can you please deal with the chat box questions, please? Maybe Tennyson and other people will come back to you a bit later, because I can see a couple of questions from younger colleagues, please.
So one of our alumni, Dr. Malik, has asked if personality is a dynamic concept. So is it true that it disappears with age as we grow old?
Yeah. I mean, it's a developmental concept, and there's a critical period in adolescence, of course, when we evolve, and we're also vulnerable to external environmental traumas. It gets better with age. That's been a conventional view, but we don't have a lot of data on chronicity and how to intervene. Maturity is an amazing thing. It just doesn't happen as quickly. So, but it's also true that if you get older, for some people, their personality features might be accentuated if they're living with new forms of challenge or adversity. If, for example, they develop a health problem, that might re-trigger aspects of their personality that were disguised or masked or managed quite well. People with dementia often, are regarded in that vein. So yes, generally things get better over time. It's not always the case, but we probably need to do more work to look at that specific question, because broadly this group is relatively neglected, and we need more work on their long-term prognosis as well. There's another question I've just seen. I'm happy to read it now. Borderline, even at a trait level, affects the treatment of patients who present with other conditions. Further, we have seen DBT work in many conditions other than BPD. Should we have a borderline traits? Should we view borderline traits in a spectrum? Yeah. So I think that's absolutely true. Very, very insightful comment there, which is relevant for all health problems. Can you imagine how difficult it is for GPs to, if they're not being trained or supported, to understand what's happening when the patient is in conflict with the receptionist or doesn't turn up for other appointments, and they usually get removed from their lists and never seen again, or given the longest wait. But there are traits that affect people's healthcare in general. If you're living in poverty and you're looking for welfare support, or you're looking for a job, are people actually trained? So there is a public health element to training people in public services as well, to understanding traits. But certainly in my practice, I rarely diagnose one disorder. I often had several, and a few traits as well, because that helped me capture the patient's presentation more accurately. And it's only for the benefit of the commissioners and the organization I work for, we'd usually tick a box. So this is the diagnosis, because we had to do that. Otherwise, the commissioners wouldn't pay the fees for the service, And so, but it's, in reality, it's a very different, complex process. But it's a great question to evaluate, and I hope lots of you early career researchers and practitioners will go away and do more stuff on this.
You have a couple more? Yeah.
Yeah.
Yes.
For the therapy of patients with borderline disorder, which is better, eclectic or specific? Right. So I guess your question specifically is DBT better or TFP? I think Tennyson might want to answer this better, and he'd probably do it better than me. But I think it's where you think the level of problem is in that complex model that Soames put forward. But they are both effective in different ways for different people. And DBT, there's quite an evidence base for that as well. Tennyson, do you want to just come in on that? Because I'm almost certain you've got a view on that.
Colleagues, it's sort of knowing your model For us to have a horse race about is one better than the other, I think is not the message we want to convey. It's if you are well practiced and you've got good training in DBT or mentalization-based treatment or transfer-focused psychotherapy, they all are effective treatments. But it goes back to Cam's slide about at which level of the brain are you working on? Because if we accept that 90% of our actions are unconscious, it does mean there's a place to think about what is your treatment and which part of the brain is it addressing. So I think that might be a way to think about, but I do think in answer that direct question, if you train in a particular model and you've got good supervision, that's a good one to use, but to realize that it might have limitations in terms of the level of the brain it's working.
Thank you. Would you also like to take the next one, Tennyson? Because I thought that might be calm. Is that all right?
Yeah, absolutely. Absolutely. Yeah.
The next one.
What are the challenges we face with the acceptance of borderline personality disorder?
One before that, respected professor, I would like to know I would like to know whether cultural differences between therapists. I think that's a very interesting question, actually. Cultural difference between the therapist and the patient, pose a challenge in the implementation of not just transference focus. I would broaden the question to any forms of psychotherapy.
Yeah, thank you for that. Yeah, it's a really important question, and I'm always inspired by work by Roland Littlewood and colleagues in the UK, but also Sudhir Kakkar in India, looking at psychoanalytic theories and adapting them. I draw on my friend and colleague Wenxin Seng's work, which looks at the philosophical adaptations and the theoretical adaptations that are required. And obviously theories differ, even the notions of Oedipus and so on differ between different groups. The fundamental core concepts are the same, but I think the styles of communication, the levels of I-centeredness versus we-centeredness, sociocentricity or individuality, the cultural influences and constraints, the embeddedness in family, all of those things are slightly different. So I'm hoping that as the workshop is rolled out over the weekend, that some of these things will come to the fore and that colleagues will adapt transference-focused therapy in the right way. But it's certainly in a cross-cultural context, it's one of the problems that we see a lot, that people are making assumptions about the other's worldview and their beliefs, either pathologizing them or not noticing the severity of them or misunderstanding idioms and metaphors. And so I think it will need some adaptation, but the core principles are the same, and yet we've got to show humility in the face of adaptation and evolve it. There's always a tension if you over-adapt and it fundamentally changes the therapy. You've really got to look at the evidence base for that you've produced a new therapy, then you've got to look at the evidence base. And I think one of your earlier questions was also, have we got too many therapies? We probably have, but they're all trying to do slightly different things and coming from different philosophical and ideological positions. But so please take that forward over the weekend, I think. What are the challenges we face with acceptance of borderline personality? I know many people who are given that label don't like it, and they find it a sort of stigmatizing indictment of their problems and some sort of condemnation, that somehow they've got this thing called a disorder and then they're disordered people. On the other hand, there are people who do benefit from it, and some people, when you either show them the criteria or they bring them in after printing it off on the internet, they're very relieved and they say, look, I understand what I've got. I've finally understood what's been going on for decades and no one's picked it up before. So it can work both ways, but there is a concern that it's become stigmatized and stereotyped by clinicians and practitioners and assume knowledge, because in our practice we create scripts, don't we? The more experienced you are, the more scripts you have, the more shortcuts you take, and so you don't actually spend time understanding the person. There is a risk that the label is perceived to be the equivalent of a biological diagnosis with certainty, fixity, parameters, and predictability of intervention outcomes over time, whereas actually a more relational approach, which I think the transference-focused therapy and transference therapies generally offer, is quite helpful, not least because you spend time listening and engendering trust and encountering all those things in the person that leads to non-trust and breakages in therapy, which at some point will happen anyway, but you're almost sensitized to it and working on that straight away from inception. It's a task for clinicians. I think that's one of the most important things we must do, is to be mindful of how we enact the objects that the patients project into us, sometimes without being aware of it. And sometimes we're over-identified with it, projective identification, and we don't understand what's happening. That's why supervision is very important in these processes.
I can see there is a number of people from the UK. I don't know you, sorry, but would anyone like to? I can see there's a large number of people from various parts. Would anyone like to make any comment, particularly focusing on, if you have an example of the transcultural differences or anything? In the meanwhile, there are a few more questions as well. Yeah, and some of them would respond. Would you like to address any of these? From an evolutionary standpoint.
Yeah. Oh, that's a very difficult question.
Yeah.
So there's a whole literature on evolutionary psychology. And I don't know if I can show you, pick out a book called Cultural Neuroscience by Joan Chow. If you can see that. You can't see it, no.
Okay.
No, you can't see it. So there's Cultural Neuroscience by Joan Chow, which actually takes an evolutionary review, which looks at the evolution of genes and culture together and argues that these are co-evolved, and that we underestimate brain plasticity in responding to our environment and our cultures. And so there is a view to learn. The problem with evolutionary theory is, how do you prove it? It's often theoretical, and we have experiments which test a specific issue, and Joan does some elegant psychological experiments. But why do they exist? So that's an interesting question. You know, why do we have? I think variation of anything is helpful to the human condition, isn't it? Because we stumble across things that are helpful, and we only hear about the negative aspects of personality because that's what we do. We do clinical work. We're psychiatrists and psychologists and therapists, and people only come to us if there's a problem. But a study of the benefits of personality disorder is a superb idea. You know, many people with borderline disorder are very, very engaging and entertaining, and I have to say rewarding to work with when they're receiving therapy, if you've understood their dilemma, if you're finally able to convey to them something that no one's ever been able to do before. And so that will be a fabulous study, a bit like we know psychoses and bipolar disorder, people love the creativity and fear losing it when they're treated and struggle with that. So I don't know the answer, but it's a great research topic to look at.
That was a great question and a great answer. Yeah.
And the final one, motivational interviewing as an approach. I think motivational interviewing is important more generally, and really, without calling it that, that's what the therapist is about, really engaging, and a slower, more intensive form of therapeutic interaction allows for someone's biography to unfold. In fact, I would say in any, more so than in psychiatry, you're really wanting to understand the biography in a different way and hearing it differently. And that in itself is motivating. And I draw on evidence there from studies of ethnography on biographical narrative interviewing, which are different from clinical work, but nonetheless allowing people to say who they really are for the first time maybe is a very powerful motivator. And there are some studies showing that if you allow people to do that, call it ethnography if you wish, clinical ethnography, they're more likely to receive the rest of the therapy, enter trials and so on. So I think without officially calling that, I think that goes on anyway. But equally so, you could argue that therapists need motivational interviewing and understand to help them understand what it is that they're dealing with when they're working with people with personality difficulties.
Yeah. So I think that was a fascinating session. I'm sure we could have gone on forever. It seems like we are just warming up, but unfortunately, all good things must come to an end, I'm afraid. So and I think we have just passed the time, which is good, but I don't know how to thank you really, but I think you have really pushed the edges, as you said. to you have brought it to a very broad canvas from the huge, I mean, normally as a clinician, unfortunately or fortunately, whatever, maybe it's adaptive because it helps us to work, we put on our blindfolds. We have to put on our blindfold because otherwise we can't work. A surgeon has to work when he has to only look at the gallbladder or the appendix or whatever. So we look at the personality disorder with a set of criteria and a set of, what we can do. I think you have broadened the canvas, put us in the middle of this entire sweep from a medical, biological, neuroscience to personality, its functions, adaptive, maladaptive functions, to social, cultural, political. We haven't talked much about that here, but anyway, I think we all understand that that's a very important aspect. What happens when a child with tremendous exposure to adverse, unthinkable levels of adverse exposure to adverse events of childhood grows up and then has a distorted personality trajectory, etc., etc. So socio-political determinants and commercial. Today's New England Journal of Medicine, today's NEJM has a whole article on political and economic determinants of health. Anyway, so on that entire background, and then taking from there to a therapeutic, to an integrated model and understanding, which I can just truly say fascinating. Hats off. And we all look forward to Tennyson, Lee, Dr. Lee and his team and others for to take it from here to its next course in the workshop coming up a few days from now.
Well, thank you very much. It's been a great honor and privilege, and Eid Mubarak to you all, and lovely to see you all.
And we can't thank you enough, and we can't pay you, but there's sorry, excuse me. Yeah, so there's a small token of appreciation as a symbolic, purely as a symbolic gesture, is a certificate of appreciation of our heartfelt gratitude to you for today's talk. And we are going to remember this, and with your consent, of course, this will put it up in the recorded version, very minorly edited, to our YouTube, so that other people can benefit from this. This was a fascinating, unforgettable experience. Swapanjit, any last words, and then we can.
Thank you, sir. It was a wonderful session. Thank you.
Absolutely. Thank you very much.
All right.
Thank you. Thank you. Bye-bye.